1. Disclaimer. I do not own the rights to the images or information provided. This was strictly made for the purpose of studying for boards. The objectives of this chapter are, first, to review the method and interpretation of the neurologic examination as it relates to localizing lesions in the spinal cord in small animals and, second, to present case studies that illustrate examples of these in 3 regions of the spinal cord, T3, L3, C1, C5, and C6. T2. Lesions from L4 through the caudal segments were described in chapter 5. It is important to remember that the neurologic examination can only determine which of these regions of the spinal cord are affected. What cannot be determined in many cases is whether or not the signs are the result of a single or focal lesion as opposed to diffuse involvement of the spinal cord segments within the anatomic diagnosis, that is, T3, L3 spinal cord segments. As the case examples illustrate, finding a focal area of discomfort or an area caudal to which a loss of the cutaneous trunci reflex or loss of sensation exists suggests a focal lesion. Despite this, the clinician should always consider the possibility of focal or diffuse lesions to account for the anatomic diagnosis presented in this chapter. Neurologic examination. The complete neurologic examination is described in chapter 21. The components referable to the spinal cord are reviewed here. There are 5 parts to the neurologic examination. 1. Examination of gait and posture. 2. Postural reactions. 3. Muscle tone and size, and spinal reflexes. 4. Cranial nerves. 5. Sensorium. Careful examination of all of these is necessary to determine whether a lesion is confined to the spinal cord and at what level. Remember that, as described in chapter 5, spinal reflexes require only the specific nerves in the spinal cord segments with which they connect, whereas postural reactions depend on the same components as the spinal reflexes plus the cranial projecting general proprioceptive (GP) pathways in the spinal cord white matter to the brainstem, cerebellum, and frontoparietal cerebrum, and the caudal projecting upper motor neuron (UMN) pathways that return from the cerebrum and brainstem and comprise tracts in the white matter of the spinal cord that terminate in the cervical and lumbosacral intumescences. These postural reactions test the integrity of nearly the entire peripheral nervous system (PNS) and the central nervous system (CNS) by themselves. Postural reactions are relatively non-localizing for a lesion. Despite this, evaluating postural reactions is critically important in determining the presence of subtle deficits that are not obvious with gait analysis alone. See postural reaction section below. Additionally, assessing postural reactions helps in determining the asymmetry of lesions. Gait. The clinical signs of UMN and GP dysfunction are described in chapters 8 and 9, and it is emphasized that most gait abnormalities involving these systems reflect a combination of UMN, spastic paresis, and GP, ataxia, clinical signs because of their close anatomic relationship. It also is strongly urged that differentiation between the clinical signs caused by disruption of these two systems is of no practical value. With spinal cord lesions that affect the UMN and GP systems between spinal cord segments T3 and L3, one tends to describe the pelvic limb gait as just ataxic or occasionally just paretic. In reality, the gait abnormality usually reflects a dysfunction of both systems and should be referred to as pelvic limb ataxia and paresis or paraparesis and pelvic limb ataxia. The same rule holds for cervical spinal cord lesions that occur between spinal cord segments C1 and C5, tetraparesis, quadriparesis, and ataxia of all 4 limbs. The terms paraplegia and tetraplegia should be used only when absolutely no voluntary movement is present in the pelvic limbs and in all 4 limbs, respectively. To observe ataxia, voluntary movement must be present. Therefore, the term ataxia is inappropriate for a paraplegic or tetraplegic animal. Patients that are recumbent in the pelvic limbs, T3, L3 lesion or in all 4 limbs, C1, C5 lesion, and show no voluntary movement when picked up and moved along the ground surface while suspended but exhibit some voluntary limb movement when recumbent should be described as non-ambulatory paraparetic or tetraparetic. The same terminology applies to lesions that involve the lumbosacral or cervical intumescence, except that the quality of the paresis reflects a lower motor neuron, LMN, dysfunction. The gait should be examined in a place where the patient can move freely, leashed or unleashed, and where the ground surface is not slippery. The floor of many examining rooms is too small and too slippery for an adequate evaluation of the gait. Moving a patient that has vertebral column injury and spinal cord contusion and is ataxic and paretic on a slippery surface may cause it to fall, and further injury may result. The availability of a corridor and an indoor-outdoor carpet is very helpful for this examination. Some fractious or aggressive animals will not attempt to walk when muzzled, provided it is safe. Try to evaluate the gait in such patients without the patient being muzzled. If necessary, use a basket muzzle, as it may be better tolerated by the patient. I use a covered outdoor area to evaluate patients with neurologic problems. It has a specialized surface that is used in many playgrounds. This surface is soft and provides excellent traction for paretic and ataxic patients. The material, Vitriturf, Hanover Specialties, Hauporge, NY, is commercially available, easily installed, and readily cleaned of feces and urine with a garden hose. It is important to evaluate the gait while you lead the patient and while an assistant leads the patient, in a straight line as well as in circles in each direction. A patient with a lesion that affects the pontomedullary or spinal cord UMN and GP systems and is still able to walk unassisted exhibits a delay in the onset of protraction, which is the swing phase of the gait, a stiff quality of movement, and often a longer stride, which is caused by a delay in the onset and termination of protraction. In the thoracic limbs, this causes a floating, overreaching action, with a limb in extension. It is important to recognize the extension of the thoracic limb joints and the prolongation of the protraction, which causes the paw to be placed on the ground farther cranially than normal. This is in contrast to the thoracic limb gait in a cerebellar disorder, where the protraction is abrupt and all the limb joints flex, causing the limb to move more dorsally toward the neck. As protraction is completed, the limb is commonly misdirected. This difference in the thoracic limb gait between a UMN, GP system dysfunction and a cerebellar dysfunction is difficult to describe but is clearly demonstrated in the videos of animals with these disorders. See chapter 13 for a description of the gait of a cerebellar disorder. In UMN, GP system disorders, on protraction, the affected limb may abduct excessively, especially on turns, when it is often referred to as circumduction. The limb may also adduct excessively before it supports weight. This may appear as a crossing of the limbs as they are advanced. Often, the dorsal surface of the paw will scuff the ground on protraction or the patient will support its weight on the dorsal surface of the paw. Occasionally, a pelvic limb is flexed excessively on protraction, creating a hypermetria in the gait. The trunk may also appear to be unstable and to sway as the patient walks, especially on turns. Remember that these clinical signs reflect dysfunction in both the UMN and the GP systems. The videos referred to in the section on diseases in this chapter clearly demonstrate what is described here. Many clinicians use a grading system to assess the degree of pelvic limb function as an aid in determining the prognosis and to evaluate response to therapy. therapy. This was originally designed for dogs with thoracolumbar spinal cord injury resulting from intervertebral disc extrusions. This is a common disorder in dogs in which numerous surgical procedures have been performed over many decades. However, it is applicable to any spinal cord lesion at any level. Grade 0 refers to a patient with no voluntary movement in the pelvic limbs and therefore is paraplegic. Grade 5 refers to a patient with normal pelvic limb function. Patients with functional grades 1 and 2 are unable to stand on the pelvic limbs without assistance. When you hold the patient up by grasping the base of the tail, and only very slight movements of the pelvic limbs occur, this patient would receive a grade of 1 for its function. If voluntary movements readily occur but are delayed, awkward, and poorly placed, the degree of function would be grade 2. A patient with grade 3 function is able to stand up in its pelvic limbs without assistance but has great difficulty and is able to walk but with significant paresis and ataxia. A patient with grade 4 function readily stands up unassisted and exhibits only mild paresis and ataxia in its gait. These are grades of function, not grades of paresis and ataxia. When we describe a grading system that is used for horses, see Chapter 11, it refers to grades of dysfunction and is used primarily for horses with cervical spinal cord disease. Postural reactions. The degree of functional deficit dictates the need for postural reaction testing. The postural reactions are always absent in all limbs of a tetraplegic patient and in the pelvic limbs of a paraplegic patient. However, in the paraplegic patient, it is very important to evaluate carefully the gait and postural reactions in the thoracic limbs to avoid missing a multifocal disorder. For example, a young dog that has become paraplegic may present to you with a progressive pelvic limb dysfunction, but you determine it also has hopping deficits in the thoracic limbs. This strongly suggests a multifocal anatomic diagnosis and a presumptive diagnosis of an inflammatory disorder such as canine distemper myelitis. You were introduced to postural reactions in Chapter 5 as they relate to examining patients with neuromuscular disorders. It is critical to remember that postural reactions essentially require that all components of the PNS and the CNS that affect the limb you are testing be intact. No individual test is available for just the UMN or just the GP system. Although a number of these postural reactions are described in the neurologic literature, in our experience, the most reliable postural reaction is the patient's ability to hop laterally on one limb. Next would be the poor placement test. Hammer walking is most useful when your patient is too large for you to be comfortable evaluating the hopping responses. Placing of the limbs is useful only in small-sized patients and when the hopping responses are equivocal. The following is the sequence of my examination of the patient after evaluating its gait. Be sure to know the name of your patient and talk to it continuously to ensure its cooperation. Make its environment as non-threatening as possible. In the hospital, I always perform my examinations on a rug or a floor with a rubber surface. Straddle the patient, with both you and the patient facing in the same direction, and palpate all of its neck, trunk, and limb muscles from cranial to caudal to determine whether there is any atrophy. After you palpate each limb, flex and extend it to determine both the muscle tone and the range of motion of the joints. If significant joint disease restricts the range of motion, it contributes to the gait disorder. When you place the limb back in its supporting position, place it on the dorsal aspect of the paw and observe how readily the patient returns the paw to its normal position. This is the poor placement test. Remember, despite what you may hear from your colleagues or read in the literature, that this is not a test for conscious proprioception. No such test exists. Be aware that some dogs are normally quite slow to replace the paw and that often the replacement of the pelvic limb paws is slower than that of the thoracic limb paws. To test thoracic limb hopping, elevate the abdomen with your left hand just enough to take the weight off the pelvic limbs. Put your left elbow on your left thigh to take the stress off your back. With your right hand, pick up the right thoracic limb and hop the patient on its left thoracic limb to the left. You should not have to move your pelvic limbs to do this. You stand still. When you have hopped the patient to the left as far as it is comfortable, change hands so that your right hand elevates the patient's abdomen and pelvic limbs and your right elbow is resting on your right thigh. With your left hand, pick up the patient's left thoracic limb and hop the patient to the right on its right thoracic limb. Keep repeating this back and forth until you are comfortable that the responses are normal or abnormal. As you stand over the patient looking down the lateral aspect of the limb that is being hopped, as soon as the shoulder region moves laterally over the paw should move. That is, hop. Any delay in this is abnormal. The hopping movement should be smooth and not irregular or excessive. The paw should never drag or land on its dorsal surface. Carefully compare one thoracic limb with the other. For pelvic limb hopping in patients that are not too large, stand beside the patient's left side and place your left forearm and hand between its thoracic limbs so that you can elevate the thorax to take the weight off its thoracic limbs. With your right hand, pick up the patient's left pelvic limb and push the patient to its right side so that it has to hop on the right pelvic limb. Then change sides and repeat this for the left pelvic limb. The responses should be brisk and smooth but will not be quite as fast as in the thoracic limbs. Abnormalities are the same as those described for the thoracic limbs. In large patients, the same observations may be made by just standing beside the patient, picking up the pelvic limb on that side, and pushing the pelvic region away from you so that the patient has to hop on the opposite pelvic limb. This can usually be done with the patient standing still on its thoracic limbs. Repeat this on each side until you are comfortable with the responses observed. As you perform these hopping responses, you will also appreciate the degree of muscle tone that is present in the limbs. In very large patients, the same hopping responses may be evaluated by hammer walking the patient. Stand beside the patient and pick up both the thoracic and pelvic limbs on that side. Push the patient away from you and observe the hopping responses in both limbs on the opposite side. Change sides and repeat this on the opposite side, and be sure that you compare the thoracic limbs with each other and the pelvic limbs with each other. Be careful in animals that are obviously paratic and in those with a history of trauma, as such animals may easily fall and further injure themselves. In small patients in which the hopping responses are difficult to interpret, it may be useful to test the placing response. Pick the patient up and bring its thoracic limbs to the edge of a table or chair so that the dorsal surface of the paw contacts the front surface of the object. The normal patient will immediately place its paws on the horizontal surface of the table or chair. Test both limbs together as well as individually. Repeat this for the pelvic limbs. Be sure to test this response while holding the patient from each side. Occasionally, for some unknown reason, a normal patient does not respond with the limbs on the side on which it is being held. It may also be useful to block the patient's vision during this test by extending its neck so that it cannot see the projecting surface of the object you are using for the test. In cooperative patients, when you are not sure of the thoracic limb function, it may help to wheelbarrow the patient with its neck held in extension. With your right or left forearm, elevate the abdomen of your patient so that the pelvic limbs are no longer supporting weight. With your other hand, hold the neck in extension and move the patient forward. In this posture, vision is compromised and there is a greater need for general proprioceptive function. In cases of mild nervous system lesions, this may cause the animal to scuff the dorsal surface of its paws or to overreach on protraction. Remember, animals in this posture will have increased extensor tone in the thoracic limbs. This is part of the normal postural reaction and should not be considered a deficit. Spinal reflexes. The patient should be placed in lateral recumbency. Usually, you will need an assistant to help hold the patient in this position. For cats and toy breeds of dogs, we find it useful to sit on the floor with our back against the wall and with our knees flexed. Place the patient between your thighs with its back resting on your thighs so that it is facing you. This is useful not only to evaluate muscle tone and spinal reflexes but also to perform the cranial nerve examination. Most patients tolerate this position quite well, and it allows you to control the patient easily. Flex and extend each limb to further appreciate the degree of muscle tone that you already assessed in the standing position and during the testing of the postural reactions. The only tendon reflex that I perform is the patellar reflex, which is an assessment of the femoral nerve and spinal cord segments L4, L5, and L6. The detailed anatomy of these tendon reflexes is described in Chapter 5. This test should be performed before testing the flexor reflexes, in which a noxious stimulus is used. Test the flexor reflexes using a pair of forceps for compressing the skin at the base of the digits. Initially, exert just enough compression to obtain a flexor response or evidence of nociception. These flexor reflexes test various components of the spinal cord segments that comprise the lumbosacral or cervical intumescence and the related nerves that supply the limb being tested. The detailed anatomy of these reflexes is described in Chapters 5 and 9. Remember that these flexor reflexes not only test the reflex arc but also determine the integrity of the nociceptive pathway to the sympathetic cerebral cortex. The latter is very important in evaluating the level of severe focal spinal cord lesions as well as in making a prognosis for those lesions. Be sure to test all of these reflexes with the patient in both left and right recumbency. When this testing has been completed and the patient is returned to the standing position, perform the cutaneous truncee reflex. You may see this reflex referred to as the panniculus reflex, but that is a misnomer because the panniculus adiposus is a layer of fat in the trunk region and is not responsible for this cutaneous reflex. See Figure 5-9. Using your forceps, gently probe or squeeze the skin just lateral to the dorsal midline, starting at the level of the pelvis, and repeat this stimulus over each vertebra on each side until you observe the cutaneous truncee muscle contracting on both sides as evidenced by the skin moving over the thorax. In many normal small animals, this may not occur until about the mid-lumbar region, and in a very few normal animals, it will not occur at all. The forceps pressure stimulates impulses in the dorsal branches of the spinal nerves that supply the area stimulated. Because of the short caudal distribution of these dorsal branches, each spinal nerve supplies the skin for a distance of about 2 vertebrae caudal to the intervertebral foramen, where the spinal nerve emerges from the vertebral canal. The general somatic afferent XA neurons that are stimulated synapse in the respective dorsal gray column on long interneurons whose axons enter the adjacent fasciculus proprius bilaterally but predominantly on the contralateral side. Here, these axons course cranially to the C8 and T1 spinal cord segments to terminate in the ventral gray columns by synapsing on the general somatic efferent neurons that via the brachial plexus comprise the lateral thoracic nerves that innervate the cutaneous truncee muscles. Recall that this reflex is lost in injuries that cause avulsion of the roots of the spinal nerves that supply the brachial plexus. In these patients, compression of the skin at any level along the trunk elicits only a cutaneous truncee reflex on the side that is opposite from the affected thoracic limb. This reflex is also helpful in determining the level and prognosis of a severe transverse spinal cord lesion such as an injury resulting from a vertebral column fracture or an intervertebral disc extrusion. Similar to nociception, it requires a bilateral transverse lesion to interfere with the pathway of these long interneurons. This cutaneous truncee reflex is especially helpful in patients that are very stoic and respond poorly to most any noxious stimulus to any part of their body. Cranial nerves. The examination of cranial nerves is described in Chapters 6 and 7. When presented with a patient that exhibits clinical signs of spinal cord disease, the cranial nerve examination is important for determining whether the spinal cord signs are part of a multifocal disease process. It is also important to determine whether the spinal cord lesion is at a level where it may interfere with the sympathetic pathway to the head and cause Horner syndrome. That syndrome is observed when the cranial nerves are examined. Summary of possible clinical signs related to spinal cord lesions. The spinal cord is divided into 4 regions on the basis of the clinical signs that are exhibited when any one of these 4 regions is affected with either a focal or diffuse disease process contained within the segments. Figure 10-1. Lumbosacral, 4th lumbar to 5th caudal spinal cord segments. A complete necrosis from the L4 through the 5 caudal spinal cord segments. 1. Flaccid paraplegia, no weight support and no voluntary movement of the pelvic limbs and tail. 2. Normal thoracic limbs. 3. Neurogenic atrophy and non-acute lesions. 4. Atonia, in pelvic limbs, anus, and tail, dilated anus. 5. No postural reactions in the pelvic limbs. 6. Areflexia, patellar, flexor, and perineal reflexes. 7. Analgesia, pelvic limbs, perineum, tail, and penis or vulva. B. Partial necrosis of gray and white matter between the L4 and the 5th caudal spinal cord segments. 1. Flaccid paraparesis and ataxia of pelvic limbs. 2. Normal thoracic limbs. 3. Mild neurogenic atrophy and non-acute lesions. 4. Hypotonia or normal tone in the pelvic limbs. 5. Postural reactions in the pelvic limbs attempted but abnormal. 6. Hyporeflexia or areflexia, patellar and flexor reflexes. 7. Hypalgesia or normal nociception, pelvic limbs, tail, perineum, penis, and vulva. C. A lesion involving the L4 and L5 spinal cord segments. Spinal roots or nerves will result in femoral nerve dysfunction and loss of the ability to support weight, creating a short stride with a flexed stifle and decreased hip flexion. D. A lesion limited to the L6, S1 spinal cord segments. Spinal roots or nerves will result in a loss of extension of the tarsus and digits and an increase in hip flexion from loss of extensor muscle tone. Weight support at the stifle is normal. Thoracolumbar, 3rd thoracic to 3rd lumbar spinal cord segments. A complete necrosis at a focal site between the 3rd thoracic and 3rd lumbar spinal cord segments. 1. Spastic paraplegia, normal reflex weight support if held up in a standing posture but no voluntary movement of the pelvic limbs or tail. Normal thoracic limbs, with peracute transverse lesions. The thoracic limbs may be hypertonic and held in extension. Sherrington Syndrome. Likewise, with peracute lesions, the pelvic limbs may be hypotonic. Spinal shock, with cranial thoracic spinal cord lesions. It may be difficult for the patient to stand up on its thoracic limbs from a recumbent position, and loss of trunk support may be evident when the patient is suspended by the base of the tail and made to walk on the thoracic limbs. The trunk may abnormally sway to the side. 2. No neurogenic atrophy. 3. Normal tone or hypertonia, spasticity, in the pelvic limbs. 4. No postural reactions in the pelvic limbs. 5. Reflexes are normal or hyperactive, patellar, +2 or +3, and flexor. 6. Cross extension may be observed with the flexor reflex. 7. Analgesia caudal to the level of the lesion by about 2 spinal cord segments. B. 8. Absent cutaneous truncee reflex caudal to the level of the lesion by about 2 spinal cord segments. Partial necrosis of gray gray and white matter at a focal site between the third thoracic and third lumbar spinal cord segments. 1. Spastic paraparesis and ataxia of pelvic limbs, with normal thoracic limbs. 2. No neurogenic atrophy. 3. Normal tone or hypertonia, spasticity, in the pelvic limbs. 4. Postural reactions attempted but abnormal in pelvic limbs. 5. Reflexes are normal or hyperactive, patellar, +2 or +3, and flexor 6. Crossed extension possibly observed with the flexor reflex. 7. Hypalgesia or normal nociception caudal to the level of the lesion. Note: lesions that affect only the white matter from L4 to L6 or L7 produce similar clinical signs. Quadricervical, 6th cervical to 2nd thoracic spinal cord segments. Complete necrosis of these segments may cause death due to loss of respirations. Partial necrosis of gray and white matter between the 6th cervical and 2nd thoracic spinal cord segments. 1. Tetraparesis and ataxia of all 4 limbs or an ambulatory tetraparesis and ataxia or tetraplegia. 2. Thoracic limb deficits may be worse because of the loss of ability to support weight. 3. Short strides in the thoracic limbs with long paretic and ataxic strides in the pelvic limbs, a 2-inch gait. 4. Thoracic limb neurogenic atrophy with non-acute lesions. 5. Postural reactions attempted if not tetraplegic and or abnormal in all 4 limbs. Thoracic limb responses may be worse. 6. Reflexes depressed or absent in the thoracic limbs and normal or hyperactive in the pelvic limbs and decreased to absent cutaneous Tronci reflex. Lesions confined to the white matter at this level of normal to hyperactive thoracic limb reflexes. 7. Crossed extension may occur with the pelvic limb flexor reflexes. 8. Hypalgesia or normal nociception in all 4 limbs or only hypalgesia in the thoracic limbs. 9. Meiosis, ptosis, protruded third eyelid, and anophthalmos with gray matter lesions between T1 and T3 or severe white matter lesions from C6 to C8. Craniocervical, 1st cervical to 5th cervical spinal cord segments. Complete necrosis of these segments causes death caused from loss of respirations. Partial necrosis of gray and white matter at a focal site between the 1st and 5th cervical spinal cord segments. Clinical signs reflect the white matter lesion. 1. Spastic tetraparesis and ataxia of all 4 limbs or non-ambulatory spastic tetraparesis and ataxia or spastic tetraplegia. Recumbent patients, when held up, exhibit hypertonia and support their weight by hyperactive extensor tone. They feel stiff when handled. This differentiates them from patients that are tetraplegic because of neuromuscular disorders that cause flaccid paralysis and that are atonic in all their muscles. 2. No neurogenic muscle atrophy and chronic lesions. 3. Postural reactions abnormal in all 4 limbs. They can be performed at all 4. Reflexes in all 4 limbs are normal or hyperactive. 5. Crossed extension may occur with the flexor reflexes. 6. Hypalgesia is possible caudal to the level of the lesion but is rarely encountered. Most cranial cervical lesions that are severe enough to cause analgesia caudal to the lesion cause death from loss of respirations. Most compressive lesions that affect the cranial cervical spinal cord segments cause more obvious clinical signs in the pelvic limbs than in the thoracic limbs. Explanations for this include the following. Lesions that compress from the periphery of the spinal cord affect primarily the superficial tracts, which contain cranially coursing GP pathways from the pelvic limbs. Figure 10-2. The pelvic limbs are further removed from the center of gravity, which is just caudal to the thoracic limbs. More UMN pathways terminate in the cervical intumescence than in the lumbosacral intumescence. Occasionally, a cervical spinal cord lesion causes more obvious clinical signs in the thoracic limbs. This is seen with quadricervical lesions that affect the gray matter in the intumescence, causing LMN signs in the thoracic limbs. With midcervical lesions, this occurs when the spinal cord lesion affects the tract closer to the gray matter and spares the more superficial tracts. These are predominantly UMN pathways to the cervical intumescence. A glioplasm that arises in the gray matter and grows peripherally toward the surface of the spinal cord will do this, as will a midline intervertebral disc protrusion that compresses the spinal cord in a dorsal and lateral direction, making the spinal cord form a tent shape over the compressing mass. This disparity in clinical signs is also seen in many dogs with an atlantoaxial subluxation as the midline dense inappropriately compresses the overlying spinal cord from the center toward the periphery. Be aware that lesions that affect the first 2 or possibly 3 cervical spinal cord segments may also cause clinical signs of vestibular system dysfunction. This presumably results from the interruption of the spinovestibular tracts that carry GP impulses from the first 3 cervical spinal nerves, which are important in the orientation of the head to the neck. 2 additional important concepts should be kept in mind when dealing with spinal cord lesions. First, lesions in the intumescences that affect the gray matter as well as the white matter present with the clinical signs of loss of the gray matter, that is, LMN clinical signs. You cannot observe UMN or GP clinical signs unless the LMN is intact. Second, a focal lesion between the C1 and C5 or T3 and L3 spinal cord segments that affects both the white matter and the gray matter causes clinical signs referable only to the white matter lesion, that is, UMN and GP clinical signs. Loss of the gray matter in a segment that innervates only the axial muscles cannot be determined by a physical neurologic examination. Only careful study with electromyography, EMG, may reveal the denervation of a segment of axial muscles. Bladder and to a lesser extent rectal dysfunction commonly accompany spinal cord lesions. These lesions were described, along with the anatomy involved, in Chapter 7. Lesions in the sacral segments result in LMN fecal and urinary incontinence. UMN incontinence is common with severe lesions of the cervical and thoracolumbar spinal cord segments. This incontinence is a primary concern in your treatment of the patient. Sherrington Syndrome and spinal shock. These 2 separate clinical disorders often present at the same time in a patient and appear to be exceptions to the rules that we have established for UMN and LMN disorders. They occur only with percute, usually transverse, spinal cord lesions between the T3 and L3 spinal cord segments. Fractures of the vertebral column are the most common cause of such lesions. Others include infarction caused by fibrocartilaginous emboli and the myelopathy associated with percute intervertebral disc extrusions. Patients with a Sherrington syndrome exhibit persistent severe extension of the thoracic limbs in most postures because of disinhibition of the extensor motor neurons in the cervical intumescence. However, when these patients are held up, the thoracic limb gait is normal except for a mild stiffness. The disinhibition is not the result of dysfunction in a UMN pathway that projects quadrantally from the brainstem, which is why these patients can walk so well with the thoracic limbs when the trunk and pelvic limbs are supported. The disinhibition is the result of a sudden loss of the axons in a long interneuronal pathway that originates from neuronal cell bodies primarily in the gray matter of the L1 to L5 spinal cord segments. These interneurons are referred to as border cells because they are located in the dorsolateral border of the ventral gray column of the lumbar spinal cord segments. Their axons course cranially in the fasciculus proprius and terminate by synapsing on thoracic limb extensor LMNs in the cervical intumescence. Figure 10-3. Their normal function is to inhibit these extensor motor neurons. This extensor release phenomenon is observed only with percute severe lesions, and it spontaneously resolves in about 10 to 14 days. The presence of the Sherrington syndrome indicates a severe lesion and a guarded prognosis but does not indicate that recovery cannot occur. Occasionally, we see Sherrington Syndrome in patients with lesions involving the cranial component of the lumbar intumescence, but this is far less common than disorders involving the T3, L3 spinal cord segments. This likely represents the greater frequency of these severe lesions in the TL region rather than in the cranial lumbar region of the spinal cord. The severe peracute thoracolumbar spinal cord lesion that is responsible for the Sherrington syndrome usually causes paraplegia because of the complete interruption in function of the UMN pathways, and it usually causes analgesia caudal to the lesion because of interruption of the nociceptive pathways. As a rule, with progressive transverse spinal cord lesions, paraplegia occurs before analgesia, which suggests that the nociceptive pathways are the most resistant to spinal cord compression and ischemia. However, in these severe peracute transverse thoracolumbar spinal cord lesions in which the Sherrington syndrome is present, usually severe pelvic limb hypotonia is present. If you examine this patient within a few hours of the onset of the paraplegia, pelvic limb tone and spinal reflexes may be absent or very depressed. These paradoxical LMN-like pelvic limb signs in a patient with a UMN pathway interruption represent what is called spinal shock. In primates, spinal shock causes areflexia and atonia for 2 to 3 weeks. In domestic animals, the areflexia, primarily the patellar reflex, is observed for only a few hours after the onset of the lesion, but the hypotonia and a depressed flexor reflex may persist for 10 to 14 days, when it is replaced by normal tone at first and then by hypertonia. The reason a UMN lesion causes LMN signs is poorly understood. One explanation is that the sudden loss of the UMN synapses, indirectly via interneurons or directly on the dendritic zones or the cell bodies of the alpha motor neurons, causes such a disruption to the LMN cell body that it cannot function for a variable period of time. In primates, more of these UMN pyramidal system synapses are directly on the LMN, which may explain the difference in reaction among species that is observed here. Some studies have found an excessive accumulation of the inhibitory neurotransmitter glycin in the lumbosacral intumescence in these patients. The basis for the release of glycin is unknown. It is important to understand this unique combination of clinical signs that results from a focal lesion in the UMN and GP systems and not make an anatomic diagnosis of a multifocal disorder in a recombinant patient that has a fracture and should not be manipulated. The basis for these clinical signs may be determined through minimal handling of the patient. With the patient lying on the floor, a table, or a stretcher, provide a rigorous noxious stimulus to a digit of a pelvic limb. No movement or just a mild reflex flexion occurs if only a few hours have elapsed after the onset of clinical signs. Note the bilateral pelvic limb hypotonia. Provide very minimal compression of a digit of one of the hyperextended thoracic limbs or just a light squeeze of that forepaw with your hand, and note the immediate vigorous voluntary withdrawal of the limb. This tells you that you have a transverse thoracolumbar spinal cord lesion with Sherrington syndrome in the thoracic limbs and spinal shock in the pelvic limbs. By providing forceps compression of the skin on the midline of the back as a noxious stimulus, starting in the caudal lumbar region and progressing cranially, a line of analgesia, a cutaneous truncee reflex, or both may be found, thus locating the focal lesion, and imaging studies may be pursued with no further manipulation of the patient. If the patient does not have a fracture, its ability to walk with the thoracic limbs when supported differentiates the Sherrington syndrome from a severe cervical spinal cord lesion. For a complete description of disorders that affect the lumbosacral spinal cord segments or the nerves associated with these segments, see the case examples of neuromuscular disease in Chapter 5.